One of the methods they're going to use is comparative effectiveness. Comparative effectiveness chooses a dollar figure for each year of life for any person. They multiply that dollar figure by how many years you are expected to live. If the cost of your diagnosis and treatment for a medical condition exceeds that number, then you don't get the treatment. I have a drastic example, but not uncommon apparently. In the United Kingdom, one of the doctors that I know did a part of his residency in the UK in the 1990s. He's a neurosurgeon. A woman from the United Kingdom coming into the hospital slipped, fell, hit her head. Unconscious. She clearly had a subdural, we call it a subdural hemorrhage. So this neurosurgery resident recognizes what's happening, scoops her up, they're going to bring her in the hospital, he's shaving her head, getting her ready for surgery, emergency surgery to get this blood out of her brain so that it stops compressing her brain. This is a life-threatening emergency, can be easily taken care of. As he's shaving her head, getting her ready for surgery, the chief of neurosurgery walks up and says, "What are you doing? You have to stop that right now." "What? We have to save this woman's life." He said, "She's 66 years old. She goes to the recovery room." And he's like, "Are you kidding me? We can save this woman's life. This is easy. This is bread and butter stuff." He says, "No, she's 66 years old. She's over the age limit. She goes to recovery," and they watched her die over 3 days. This is what comparative effectiveness can do. So, other areas that they are looking to save money: decreased reimbursement to providers through accountable care organizations and the Independent Payment Advisory Board.
That's covered in the next video, but we need to talk about comparative effectiveness.
The end of this #2 video was, to me, one of the most sad things about all this, and really struck home. Again, our chairman at Norwalk Hospital, Dr. Hunter, was from England. He said that, like, I would do maybe one hysterectomy some mornings at Norwalk Hospital, where you take out the lady's uterus and tubes for whatever reasons, bleeding, cancer, whatever. Sometimes I do two. I didn't really like to do two because it's a fair amount of stress. Dr. Hunter laughed. He said, "You know, in England, I used to do between 6 and 7, but I had to be done by 1 o'clock because clinic started at 1. So clinic was from 1 to 5 o'clock. He said, "I saw 90 patients in clinic." See, everybody thinks they're going to get the same care they're getting, but somebody else will pay for it. For me, I would start maybe 7:30, quarter to 8. I try to start early because the women love to like shoot through on the way to work, and I'd often worked about 5:30 or 6. So if I saw 33 patients, to try to put that in perspective, was a lot. You know, the gynecology exams might be 20, 30 minutes. Some are quick. A pregnancy visit's quick, taking out the staples, but 33 was a pretty full day. But just in the afternoon in England, he used to see 90. He said, "I couldn't be late for clinic." So, and yet, I'm sure they got good care. Now, this may be slightly out of date too, but generally in England, if you're 55 and you need a kidney transplant, they say, "Here's some pills, go home." So, yeah.
I just heard a few days ago that kidney, this has already changed, that kidney transplants in the U.S. now will not be on a waiting list for who's been waiting the longest, but it will be based on the person who's youngest, moving to the front of the line and getting the kidney.
And that goes against what the law for the last few years has been. You couldn't discriminate by things like age or disability and stuff. So that's.
And is it true? I heard this last year or sometime, but under actually, you know, Obama in the debate 2 nights ago said he liked the term Obamacare. So I think it's okay if we call it that, if he likes it. Anyway, I heard that under Obamacare, even if you had the money to pay for something yourself, but if this iPad said it didn't meet the criteria, then you would not be allowed to have it.
Right.
Is that
We're going to
true?
get into that with mammograms and the prostate test too. You had a question?
Yes, I just wanted to ask you, you used that example of the 66-year-old person. Well, under this situation, would there be a difference between a 66-year-old person and an 80-year-old person?
It'd be worse. And
It
we're
would
going to
be
get into
worse.
that with mammograms. At 75, they're just going to say to the woman, "You're not getting any more.
That's right.
You don't matter." That's going to be at the end of
Also,
video 5.
I lived in Europe for 10 years, so I know pretty much what's going on over there.
Let me just touch, oh yeah.
And if you had money and could go to a
Yes.
private clinic, you got treated. If you didn't, tough luck.
Well, that's one thing you mentioned, Australia. They have two systems. They have sort of a government system, and then if you're a little wealthier, you can have a second private system where you get treated. England, apparently the big thing was to build private hospitals so people didn't have to sit in a wheelchair for 2 years waiting for their hip. I just want to touch on Medicare and Medicaid. I always took anybody that came into my door, but I got to say Medicaid and Medicare, the doctor is losing money on everybody that comes in the door. Now, her mom and my mom are 90, and they're pretty well off, you know, thanks to real estate going up over 50 years. But I say to them, you know, the doctor is just seeing you because he's kind, because in every Medicare, Medicaid you take to the operating room, you're also losing money, or Medicaid, they used to pay us $605 for the whole 9 months of care and the delivery of the baby, then it went up to about $900, then it went a little higher. But a few years back when I looked, we were getting about $67 for the entire gynecology visit for the Medicare. And there was a copay of $17. Now, it's never worth it to ask the lady for the copay. By the time you do the billing, it's not worth it. But just to be annoying, Medicare forbids you to ask the lady. Well, she's right there, she's got the money. And remember, we had a New Canaan office, among others. Trust me, they're coming in the Mercedes, and they're not worried about the money. But if she was to give you personally like $10 for some reason, they kick you out for 2 years. And we'll get into the fraud, because there's going to be over 1 million pages of regulations, and the doctor, even if he doesn't know he's breaking a rule, is still considered guilty. In fact, if you as the patient didn't follow the directions and didn't get better, the doctor won't get paid. So it's going to be a nightmare. And I wanted to touch on something. My dad started practicing in Wilton in Norwalk in 1954. It was so easy. The patient came in and gave him like 15 bucks out of his pocket. You kept the prices low. My mom was there on the telephone. You know, they just paid you. It was so simple. So one time, my dad always did house calls. One time it was the middle of the night, and the people didn't have money, so they gave him a painting. He came home with this big painting that's still by my mother's bed. And I'll tell you one more funny story. The gentleman, Chris, my friend in the blue shirt here, about 1.5 years ago, he asked me to go up to New Milford. There was about 250 people on the mall, on the green there, and he wanted me to talk. And of course, my fly was down. Nobody wanted to tell the doctor that, you know, so I gave him a whole talk. So after the talk, this one older gentleman, he's just about 80, came up to me, and he said, 53 years ago, your father saved my daughter's life. He sat with her all night long in the hospital, and he saved her life, and he only charged me $75 the next morning. And I said, Doc, that's not enough. But I think when I see the complexity here, my wife works for oral surgeons. She sits there all day long trying to do these CPT codes, and then somebody doesn't dot the I the right way and doesn't get paid. I think it was so simple, and it kept prices down if you had to pay the guy. Now, we used to take, as I said, anybody that came to the door. Every day we'd have 1 or 2 women didn't have insurance, and we wouldn't charge them, because, you know, we'd see on the chart, and they'd feel bad. People don't want charity. We'd say, Mrs. So-and-so, we delivered your baby, we tied your tubes. When you get insurance, we'll charge you. We used to do a few hysterectomies, a few deliveries a year for free. They're going to show that that gets to be forbidden in this care. I don't mean to do all the talking, sorry. Yes.
I wanted to say something about
sure.
the chart, if I could, because we were talking about comparative effectiveness. And so I made this chart to show you that one of the authors of our new law, Ezekiel Emanuel, is working with the Department of Ethics on different ways to find out the value of your life. So some of the ways are the youngest first, there's all different systems, but the one that Ezekiel Emanuel has come up with is this complete live system. So as you see, at 0 age, you don't have much value. Your value rises as you get some education, get a little older. Your peak value is up there, and then as you get older, your value becomes less and less and less and less. And remember that we are being given a law that will increase our insurance coverage, increase all the people who will receive it, and decrease the costs. How will that happen? So when she talks about comparative effectiveness in this law, you can see that in different ways. They can compare this procedure to that procedure, see which one is better for you, choose the better one. However, when they compare this procedure and that procedure, and the main determining factor is cost, that's what really worries me. This is the complete life system, the Department of Ethics.
I wonder if your local priest how he would draw the line in town. Sir?